Super. And you can hear me okay?
Yes.
Okay. Super. Sorry about this, folks. Okay, so I'm Dr. Gee, and I'm a practicing obstetrician gynecologist and formerly Secretary of Health for the Louisiana Department of Health, a former professor of healthcare quality improvement at the School of Public Health, and now back at LSU as CEO of Healthcare Services. And I'm delighted to be with you today. So, certainly Louisiana was disproportionately impacted early on by the COVID epidemic. We likely as a result of Mardi Gras being at the very time at which COVID was silently spreading throughout the nation, and before this was known by healthcare and public health experts, we had one of the earliest spikes, New York and New Orleans being some of the highest growth early on, and our growth in fact looks similar to Italy with about a 78% growth in the first 2 weeks of the epidemic. So really faced some of these issues earlier here than in other states and more acutely. And on March 11th, Governor Edwards declared COVID-19 a public health emergency in Louisiana. And very quickly, our campus shifted to visual learning. See if I can get this to go down. On March 15th, a stay-at-home order was lifted and Louisiana shifted to phase 1. And then on May 18th, we brought students back to clinical clerkship in person. And so it's certainly been a challenging journey, and one at which we've had to be a little bit ahead of the curve as we've figured this out, but one at which we feel we've successfully navigated. In terms of the impact and lessons from COVID-19 response, we did have a lot of issues with step 1 and 2 exams that were delayed or canceled because of office closures, and students certainly were not allowed to visit potential residency sites, and interviews shifted to online platforms, which has made it very challenging for students to get the feel of what a residency program looks like, the typical types of relationship building and interactions that occur have been unavailable to our students. Also, increased interaction with and transparency from faculty, I think, praised students in helping mitigate anxiety. There were, through the ability to have more online interactions, we were able to have more regular interactions, particularly between our second, third, and fourth year students. And that, I think, helped mitigate anxiety. Also being able to say during this time, look, there are things that we just don't know. And being honest and open with students was very helpful. Also, student access to clinical learning opportunities during the height of COVID-19 was largely unavailable. One of the things that was reinforced was that medical students are sometimes the last priority, and due to PPE shortages, and certainly the first month of this epidemic looks very much and felt very much like an auction environment, where we were, whether it was for ventilators or PPE, not only bidding against other health systems, but bidding against other states and sometimes against the federal government. There was a time at which we received outdated stock from PPE from the Strategic National Stockpile. And so, it was very difficult to get adequate PPE early on. And we did find that medical students were, not the top priority for PPE, and that made it very difficult to, have them in clinical settings safely. I think that we've learned that our students are doing well with online education. In fact, some of our testing reveals that they're doing better than pre-COVID. So I think that that this online environment as a new normal may not have negatively impacted education to the extent that we might have feared. And that's a positive takeaway. So I think the other issue is that I think one learning is that nurses seem to be a little bit more easily integrated into the healthcare team, and that nurses were sometimes a higher priority than medical students. So I think thinking about, certainly doctors are, the physician training programs teach more critical thinking and are, as a leader of the healthcare team, the physician is required to make decisions above and beyond what might be a typical clinical decision-making protocol. And so, although it would be nice to have the physicians needed and available and integrated into teams as early as the nurses, there are just some challenges, and think intrinsic to medical education, that can make that difficult. I also think that one of the things that we learned is that medical students are extremely able and enthusiastic and unafraid of volunteering and being part of the team, and have very quickly set in, whether it's our own COVID clinic at LSU, testing our faculty, staff, and students, volunteering to do contact tracing efforts, working with the city or the state. At one point, we created an online student volunteer site that had over 3,000 names in healthcare areas, both nursing, physician assistants, dentists, and doctors. And so I do think we were reminded that people go into medicine because they care about patients and they want to take care of others, and they believe in caregiving, and that their desire to do so was reinforced, and opportunities to help were reinforced through COVID. So there are some positive takeaways, but certainly I think the most challenging parts have been early on the PPE shortage, and then more recently helping folks navigate where to go for residency. And what we are hearing and expect to see is that people may be choosing locations closer to home just because they're more comfortable with those locations, and COVID has brought to the fore the importance of family and connections, and so those things may play into the match process. So I know that I have 10 minutes left, and I apologize for the technical difficulties, but just want to thank my colleagues at LSU who are phenomenal leaders and have really maximize the opportunities for student learning in what has been a very difficult environment, and just recognize our own students, faculty, and staff who have just been incredible throughout this entire COVID epidemic. And it gives me hope for the future generation, and that we're going to be in very good hands with the next generation of clinicians that we're training. So I will stop there and answer any questions. And I think that I stopped sharing my screen, but you should be able to see video of me, but I'm not sure because I can't see that on my screen.
Thank you so much, Dr. Gee. Personally, I can't see you. I'm not sure if the rest of the audience can, but we do have a couple of questions. So our first question is, with schools increasingly integrating online learning into their curriculums, do you think online learning will stay after the pandemic?
Yeah, I absolutely do. I think that certainly there are a couple things have been clear. I think one is that telemedicine is here to stay. I think that what we do know is that many patients prefer it, that it has worked very well in some settings, and that there will be growth in telemedicine. And so I both expect that the clinical training environment will include more training around televisits and teleinteraction, but also that, given that we see some positive indications of the scores that our students are receiving on tests, and that online or remote learning was successful, I think that it makes a lot of sense to continue. Certainly anatomy lab is something that is very challenging remotely. There are certain things, whether it's, the tactical feel of a suture in your hand, or learning how to examine a patient, and certainly the clinical skills exam was canceled, and that's going to be a deficit in terms of how we're going to be able to evaluate our students. There are certain things that need to be done in person, but there are others that just don't. And so I think that we'll take away the good of this, and probably as we develop a vaccine and the world normalizes, some of the things that have made it more difficult will go back to in person. And Amna Prata, I think your screen is my screen, so I don't know if you're able to allow me to show my Zoom. And if we could, you could see my video, but I don't know if that's fixable. You can try to.
Are you guys able to see both of us? If someone can respond in the comments.
Just you, Amna.
Okay, I'll turn my video off, Dr. Gee.
Yeah, it might be that we've got, okay, because the link you sent me, I think might be your personal link.
So for the next question, how is virtual learning affecting standardized testing? So MCAT, PCAT, and board licensure exams.
How will it impact board licensure exams?
And standardized testing in general.
Okay, it's still not allowing me to show video, but I was trying. Can you hear me okay?
Yes.
Yeah, so I don't know that things will change a lot. I think, as I stated earlier, I think that, the hands-on clinical skills exam obviously cannot be done remotely. Exams have been taken remotely previously, and I don't see any big differences there, other than I think the preparation for them and the classwork that is done to prepare for them will likely involve more remote learning going forward, just because certain students prefer it. And I probably would envision classrooms in the future where you can choose whether you want to do remote or be there in person. And I think there are some benefits to it. Certainly there are, and my colleagues at Mass General have been doing very successfully, for example, grand rounds, which previously, might have had 20 people and now have 300 or 350 participants. So I think one of the benefits of COVID is that there has been light speed increase in the availability of online materials that are excellent, are approachable, and are available for students. So I would see that the online learning environment has already improved dramatically and will continue to. I think in terms of the tests and skills that are needed and are evaluated for the purposes of licensure and to determine if someone is capable of being a physician probably won't change very much.
Thank you. Our next question is, what measures should be taken to ensure that students stay motivated and connected with their teachers during this time?
I think it's similar to what LSU has done. I think it's very important to have some listening sessions and learning sessions that are available to students. Open hours, being physically present is nice and certainly promotes intimacy with students, but I think also just being able to be available online has been really important and should be something that folks consider. Even if you can't do open hours in person a week, it's been very nice to have the availability to do open hours with students. And so, having that accessibility and availability, whether it's in person or remote, I think is very effective.
Thank you. We have another question asking, are institutions being more lenient about requirements of getting into medical school?
So I am not on the admissions committee, and I'm not an expert in that, but I would not think that is the case. In fact, I would guess that probably more people want to go into medicine. Certainly public health is seeing a lot of folks interested because these issues are just so prominent in people's minds. So I would not think so, and I'm not aware of our standards going down, and would be surprised if they have in relationship to the epidemic. And did want to thank Dr. English and Dr. Lazarus, I think one of whom might have been on earlier, who really have been the rock stars at LSU and have been in charge of this process. And as someone who has students who have followed me or have been fellows this summer, I can tell you that they have been, very, very well supported. And so I just wanted to highlight and thank those two phenomenal leaders at LSU for all of their efforts at this time.
Thank you. I'm not sure if you're familiar with iHuman cases, but a participant asked, do you see a benefit of iHuman cases being used for clinicals?
So I'm sorry, I'm not. I'd love to know more. But I can't answer this question because I don't know what iHumans are, unless you're talking about, Android, type of humans that are for simulation centers. But if that's what you're talking about, I can pontificate. But otherwise, maybe we can table the question.
Okay, we'll see if the audience provides a little bit more clarification because I'm not too familiar with iHealth either. In the meantime, we do have another question. Do you think schools that are reopening are taking effective implications to make it safe?
I think it's challenging. One of the failures of the federal government, in my view, is that they have been slow to protect, or in some cases have been lacking or negligent in the protection of individuals in the workforce. And what I mean by that is we have institutions like the Occupational Safety and Health Administration or the National Institute of Occupational Safety and Health that ideally would have put out guidelines that are optimal for the protection of both healthcare workforce and essential workers, and that has not been done. And so, and you've also had a lot of mixed messaging on masks, a lot of mixed messaging on testing, a lack of clarity on consistent guidelines, whether that's on testing, contact tracing. And certainly some of this is unavoidable because this is an unprecedented crisis, but some of this, in my view, should have been federally driven, because in the absence of federal leadership, you have individual colleges, universities, and health sciences centers making up their own rules and doing the best they can, but without a well-coordinated approach at the national level. And as a member of the National Academy of Medicine, I've attempted to bring together academic institutions across the country to create the conditions for some uniform policies and procedures, and it's just been very difficult. So I do think that campuses are doing their best, but the ideal, you have great disparities in access. So for example, Harvard University is testing undergraduates 3 times a week through the Broad Institute, and then you have other undergraduate campuses that are not going to test at all. And the same is, may be true, although there isn't good reporting on all of the different procedures of each health sciences center or academic medical center. We at LSU are using antibody testing with a follow-up virus test. Others are using virus tests. And again, I think without having this moonshot scientific community process where we get together, quickly evaluate the best evidence, bring together large data sets, and evaluate, it is kind of every campus for itself. And I think we're going to have a wide variety of outcomes from the various approaches. I do think, and one thing I'm working to organize now, that we should evaluate these different approaches so that at least for spring semester, we know what works and what doesn't.
Thank you. I think we have time for one more question. How are school administrators in city districts ensuring every student has access to technology such as computer, headphones, access to stable Wi-Fi, etc.?
Say that one more time.
The question was, how are school administrators in city districts ensuring every student has access to technology, including computer, headphones, and access to stable Wi-Fi?
So Wi-Fi access is a really important issue, particularly in rural communities and in many urban communities. I think that is an issue that is beyond what most universities are able to solve, but certainly an issue of health equity that needs to be addressed at a national level, particularly when we think about not just higher education learning, but K through 12. So I think that this highlights the need for national policy national policy approaches to address this problem. I think, certainly things campuses can do, and I'm not aware of what we are doing in terms of internet access, but you can give MiFi cards, you can ensure that you have on-campus access, make sure that you have safe places for students to study, and make sure that their internet access is adequate in those areas. But I do think we have a lot of work to do as a nation to ensure that every student at every institution has access to the internet.
And then follow up to a question we had earlier about iHuman software. So iHuman software is a patient simulation software, which integrates integrated learning, exercises, and assessments to fully understand cases and remediate if they make the incorrect decision. So I believe the question was, do we think that with the online learning, will we see a more integration of a software such as iHuman?
I mean, I think with online learning, we're going to see a lot of innovation in the digital space. And again, not having direct experience with iHuman, I wouldn't want to comment on that application, but I think, we've had a revolution in how we take in information, how we teach and train, whether it's, kindergartners or medical students. And I expect that out of this, renaissance of digital information will come a lot of new approaches to learning and teaching that we would previously not have envisioned. So yes, I think there's a lot of areas that will grow and develop because I think that there's a new normal that's something that we found is very successful, and I'm sure many will find an opportunity to build on.
Thank you so much, Dr. Gee. We appreciate your time and apologize for the technological issues.
No problem. It looks like my email, you guys had the wrong email for me. So what I'm going to do also to all the participants is share my email. So if there is a question that you didn't get to ask, then myself or my colleagues at LSU would love to engage. And I'm sorry that we had technical difficulties, but it seems like also the new normal is some of these types of things. But I appreciate you sharing your time with me, and send my very best wishes.